Okay, so now I would like to welcome our speakers. We have Dr. Keith Naylor. He is the assistant professor. He is an assistant professor in the College of Medicine, and he is also a gastroenterologist at UI Health. We have Dr. Lisa Tusing Humphreys. She is an associate professor in the Department of Kinesiology and Nutrition at UIC. And she's also a co-leader for a cancer prevention and control program. And then we also have Candace Henley, who is the founder and chief surviving officer of the Blue Hat Foundation. So thank you again for joining us today. Now I would like to give the floor to Dr. Lisa Tusing Humphreys. Dr. Tusing Humphreys, you can go ahead and share your slides. Let me stop sharing my screen.
Melissa, is Keith gonna go second then?
Yes.
Okay, great. Can you see my slides?
Yes, we can see them.
Great. Well, welcome everyone to today's event, and thank you to the CHEK team for hosting. And I think we have a really great panel of speakers today, and I'm excited to join both Keith and Candace in our discussion today. I'm going to talk a little bit about, and just for a few minutes, I think each of us, Candace, Keith, and myself, could each probably go for an hour. So this could have been a 3-hour ordeal, but I'm just going to briefly touch on lifestyle factors in colorectal cancer prevention. And I'm going to talk some about diet, body weight, as well as chronic stress, because that's becoming an emerging area that we're seeing as contributing to cancer risk and uniquely to colorectal cancer risk. So I just want to briefly, in this very kind of simple cartoon, show you how food, nutrition, obesity, and physical activity, as well as other exposures like smoking, can contribute to the development of cancer. So as you can see here from this slide, with those lifestyle factors centered in the middle, they can impact pathways in our body that are associated with the development of cancer. Also, different foodstuffs, as well as maintaining a healthy body weight and being more physically active, can downregulate some of these pathways that we know are associated with the development of cancer. Unique to colorectal cancer is that what we consume daily in our meals and beverages comes into direct contact with our colon tissue. So our diet is very unique in its way that it interacts with our colon and can be protective or promote the development of colon-related diseases such as cancer. One aspect that we focus on a lot in terms of research and how diet and body weight, as well as physical activity, might contribute to the development of cancers is through its effects on the immune system. Diet and body weight, as well as physical activity, can impact the immune system in a way skewing it toward less inflammation or more inflammation. So excess body weight and a diet that's rich in animal proteins and saturated fat can actually promote and trigger the immune system to be more pro-inflammatory. And cancer loves to really take shape in these inflamed tissues. And that's why this is an important mechanism that we study closely as it relates to lifestyle behaviors and the development of cancer and colorectal cancer. So this slide literally summarizes, and I didn't do the summary, summarizes thousands of research studies to look at the association between diet, nutrition, physical activity, body weight, and colorectal cancer. And this was published in 2017 from a group of researchers across several countries that look at the scientific evidence as it relates to these exposures in the development of cancer at several sites in the body. And this is their summary for colorectal cancer. So how they present this systematic review of the research is that they group it as strong evidence or weak evidence. And here on the slide, I'm presenting to you the strong evidence around diet, nutrition, physical activity, and colorectal cancer. And then it's subgroups of convincing or probable, and then exposures that decrease risk or increase a person's risk. So you can see from this slide that several lifestyle factors that can decrease your risk for colorectal cancer include physical activity. The evidence is convincing around this exposure. And then other strong evidence around exposures for decreasing risk include consuming whole grain foods, consuming foods that contain dietary fiber, dairy products, as well as calcium supplements. And then on the in the red column, these are exposures that would increase a person's risk for colorectal cancer based on the evidence. And this includes processed meats such as luncheon meats, hot dogs, sausages, alcoholic beverages, a person's body fatness with importance given to the amount of body fat that you have in your central region around your organs. Something we can't change, how tall a person is a risk factor for colorectal cancer. And also it's shown that red meat consumption is linked to increased risk for colorectal cancer. The majority of this evidence is from studies where we observe large populations of people. We're not necessarily asking them to adopt a diet or intervene, but we're just observing what they consume in their natural day-to-day life. And these are the exposures that pop out as decreasing a person's risk or increasing a person's risk. So even though I just talked about a few dietary factors that can impact your risk, we don't eat just fiber or just whole grains. We really eat in what's called a dietary pattern. So in a given food or a given meal, you're exposed to thousands of different factors within that food or meal at times. And what we're finding and what we're moving toward is understanding how a person's full dietary pattern protects them from diseases, including cancer, or promotes the development of diseases, including colorectal cancer. And what we know from these studies, and again, most of these have been observational where we're just looking at habits within large populations, is that people who consume a diet, what's called a Western type of diet, rich in processed foods, fast foods, animal proteins, animal fats, and added sugars, is associated with increased risk for colorectal cancer. Whereas we see dietary patterns such as the DASH diet, which was actually developed for blood pressure control, as well as the Mediterranean diet, are protective. So these protect people, or what we can see from these observational studies where we're just kind of seeing what people are doing. When they are eating this type of pattern, they have lower rates of colorectal cancer. And you can see from these pictures that really the defining feature of both the DASH and the Mediterranean diet is that they're rich in plant-based products, whole grains, fibers, fruits and vegetables, and there's lower intake of animal-based products like meats and dairy products. What's interesting is that we see this in the scientific literature that these diets are protective, but we don't really know why they're protective. And we actually have a new study that's being launched this summer at UIC, funded by the National Cancer Institute, to understand why a Mediterranean diet or adopting a Mediterranean diet protects a person from developing colorectal cancer. And we're also interested in layering a Mediterranean diet with weight loss to see if that gives an individual even more protection and why it gives them protection. So if you're interested in learning more about that study, please do reach out to me. Another lifestyle factor that my research is focused in on is also a person's chronic stress exposure. So this is not something like a single one-off response, but when somebody is taxed daily, where they are having anxiety, depression, and other mental health issues, but having these daily chronic stressors, this elicits a biological response in this individual. And we're finding out that, similar to diet, chronic stress through production of different chemicals in our body called glucocorticoids or cortisol can actually trigger some of the same pathways that are known in terms of promoting the development of cancer in an individual's body. And why this is unique to colorectal cancer is because we know there's really close communication between our brain and gut. And a lot of this communication happens through the gut microbiome, or the microbes that we actually have in our colon. And what we see is that when people have chronic stress or other mental health disorders, this relationship is disrupted such that it's promoting more inflammation in the colon and also systemically in that person, and really setting them up for more chronic diseases, including the development of colorectal cancer. Also, when you layer this on top of a poor diet, you really put this individual in a position for great risk for chronic diseases, and in particular, colorectal cancer. So this is emerging as an important area in prevention for colorectal cancer. So just two more slides, just briefly summarizing how to kind of think about what an appropriate dietary pattern might look like for preventing colorectal cancer. This is called the New American Plate. This is from the American Institute for Cancer Research. What it's showing you really is just a visual what your meal plate should look like. And this is really taking cues from the DASH diet and from the Mediterranean diet, where your diet, your plate is about 1/3 of animal-based proteins or animal sources. And then the other 2/3 of your plate is fruits, vegetables, and whole grains. And then I think also in terms of wellness and reducing stress, it's also important that we are paying attention to our mind and our stress levels, getting enough sleep, exercising in combination with having a healthier diet pattern. So it's estimated that if we were to adopt as a society some of these healthier patterns, such as maintaining a healthy body weight, being more active, and shifting our diet so that it's more plant-based and reducing our alcohol consumption, we could prevent almost half of new colorectal cancers. However, I would be remiss not to talk about this, that isn't easy for all of the Chicagoans that we work with and we engage with on a daily basis. And it really does go beyond what the individual behavior is. So just using food as an example. So if I were to take in dietary fiber, my body may react differently than if Melissa was to take in dietary fiber because of her genetic background or her response to that particular dietary exposure. And then for some individuals, it's not so simple as to just eat a healthier pattern because of some of the barriers that they face in their neighborhood or from society in general. For example, we know that many of the neighborhoods that we serve here through UI Health as well as through CHECK, that it's not easy to go be physically active in that neighborhood. And the food, there might be low healthy food availability in that neighborhood. So really understanding how these different factors interplay to promote or prevent disease is really important to us. And this is important work that we're doing through CHECK with our community partners. And with that, I'll stop and pass it over to, I think, Keith. But thank you so much, and I look forward to your questions.
Hello, everyone. Hopefully you can hear me. I had to call in using my phone. I see Lisa shaking her head, so that's good. I apologize for the technical difficulties at the initial piece. My desktop computer, for some reason, I couldn't actually join with audio or video. But it's a pleasure to have an opportunity to speak today, and I'm certainly happy to discuss any questions that come up. My portion of the presentation is focused on colorectal screening and prevention through screening, which is something that I'm personally very passionate about as a gastroenterologist. Go to the next slide, please. I wanted to start by giving some background about colorectal cancer as a whole. So in terms of common cancers, colorectal cancer is the third most common cancer diagnosed in both men and women. And as you can see, there's many cancers that are very common amongst men and women, but colorectal cancer is actually one of the most preventable and where screening actually makes the most difference. Next slide, please. And that's just highlighting the colorectal cancer as being the third most common. So unfortunately, from a public health standpoint, colorectal cancer continues to be a huge issue in the United States, causing more than 50,000 deaths in the last year. But the other issue with it being one of the most common cancers is your overall risk of developing colorectal cancer over the course of your life without screening is about 1 in every 20 people. So it's very important that we use screening as a way to decrease the number of people that actually are diagnosed, and also try to diagnose the disease as early as possible to really get the full benefit of treatment. Most cases of colorectal cancer, unfortunately, are actually found in people who don't have any family history of colorectal cancer. Any way we could really identify them for appropriate screening other than sort of screening with your primary care doctor. So even if you don't know someone in your family, like a parent, grandparent, or a sibling with colorectal cancer, it doesn't really completely lower your risk. So it's important to still get screened. The really beauty of colorectal cancer in regards to screening is our screening tests can generally detect cancer at an early stage, as well as in some cases even prevent the development of colorectal cancer. And over the last 40 years, the mortality from colorectal cancer has actually been cut almost in half as we've improved our screening across the country. Next slide, please. So, just to get us all comfortable with the colon, as a gastroenterologist, I talk about the colon all the time, and I'm very comfortable with all the aspects of the colon. But I think we all have a very interesting relationship with our colons. Many people feel very not the most comfortable discussing issues related to their colons with their spouses or even sometimes with their doctors. But I think when it comes to colorectal cancer, we need to be very comfortable with having the discussion about screening and issues that may increase our risk of colorectal cancer. So the colon is the large intestine. It wraps around the body like a question mark that's shown here in the image. And colorectal cancer is a cancer that occurs within the colon. Next slide, please. This is just an image similar to what I would see during a colonoscopy that shows a polyp in the colon, and that's that small sort of area that's bulging out almost like a little mushroom on the left side. That's a typical polyp that we would find during colonoscopy, and it's just to show that polyps are one of the things we're looking for during screening, but also we're looking to identify cancers at an early stage. Next slide, please. The importance of identifying polyps in cancers is that with colon cancer and all cancers actually, we can identify things either before they become a cancer or very early on in the process of becoming a cancer. The likelihood of providing someone a cure and removing all the disease, or providing them with a type of care that's going to provide them the longest survival after their diagnosis, is really dependent on finding things as early as possible. And with colonoscopy or with certain types of colorectal cancer screening, the goal is to actually identify polyps, which are the growths that I just showed in the cancer, in the colon before they become cancer, and to remove them so they never have an opportunity to become cancer. So what you'll see on the left side of the image are polyps, and over the course of about 10 years, it's believed that some polyps can develop into cancers. And you'll see as the image moves to the right, there is evidence of first what's called dysplasia, which is like a cancer-like change within the polyp. And then eventually that can become a cancer where there's invasion of the cancer into the wall of the colon. And on the far right, the cancer is invaded all the way through the wall of the colon. So the goal really with screening and detection is to find either polyps or cancers before they have an opportunity to invade through the colon and potentially spread to other areas. Next slide, please. So the reason that's very important is we know by finding cancers as early as possible, we really extend people's ability to survive after a cancer diagnosis. So what this slide shows is the percentage of people that are alive after 5 years after having a diagnosis of colorectal cancer. And for local disease, which is something that's within the wall of the colon, the survival rate is 94%, which is actually quite good considering it's a cancer. And you can oftentimes have a cure if we can remove the cancer before it has an opportunity to spread into the colon or beyond the colon. Whereas if you have regional or distant disease, your risk of having death related to cancer is much higher. So the goal is really to find people at that local or early stage, or even to prevent cancer before it has an opportunity to invade. Next slide, please. So the government has actually come up with screening guidelines that apply to all healthy individuals to try to identify people at the earliest possible opportunity to both prevent and detect colorectal cancer. So the United States Preventative Task Force is part of the governmental structure that provides guidelines for screening. And they've recommended that all healthy individuals, independent of any known family history, should undergo colorectal cancer screening right now through their recommendations, beginning at the age of 50 up until the age of 75. And then after the age of 75, actually, you can continue to get screening, but it should be really individualized based on your health and your other history, either related to cancer or other conditions. But everyone between the age of 50 to 75 who's healthy should undergo screening in order to hopefully prevent and identify disease at the earliest possible opportunity. Next slide, please. So I put this slide forth because most of us are very familiar with Chadwick Boseman and his unfortunate passing as a result of colorectal cancer. And I put this up as an indicator of someone who was younger than the age of 50 when they were diagnosed. And unfortunately, he was diagnosed in his early 40s with stage 3 colorectal cancer, and then passed away within the 5 years of his diagnosis. So he represents someone that didn't really fall into those screening guidelines. And right now there's a discussion about decreasing the age of screening to 45 in order to detect people who may be younger before they unfortunately may be diagnosed with something that could potentially shorten their life. The thing to be aware of, though, is colorectal cancer is still 90% of colorectal cancers are diagnosed in people after the age of 50. So the majority of colorectal cancers still occur in people after the age of 50, but there is a very important population of people who can be diagnosed earlier. And I'll talk about some ways that we can identify that group towards the end of the talk. Next slide, please. So in terms of the different kinds of screening tests, there are several different tests that have been approved and are known to reduce mortality related to colorectal cancer. The two most common being tests of the stool that try to detect small amounts of blood that can't be visually seen in the stool. And those would be things like a GLIAC-based stool test or a fecal immunochemical test, or lastly, some of the newer tests which actually look for DNA from cancers in the stool. Those are all stool-based tests that can be performed at home and then are usually brought back to the doctor. And if they're positive, then someone may need to undergo a secondary test like a colonoscopy to actually see if they have a cancer, because these tests don't diagnose cancer. They're screening exams that let you know if you may benefit from further testing. Now, the second type of test is a test that actually looks within the colon, colonoscopy being the most common, but there's also a shorter version called flexible sigmoidoscopy that's not as commonly done these days, as well as certain kinds of imaging tests like CT scans that can look for the presence of polyps or cancer within the colon. And colonoscopy right now in the US is the most common way that we do colorectal cancer screening, but the stool-based tests are also common, and they're also very important at preventing and detecting early stage cancer. Next slide, please. So this is just a quick image of one of the stool-based tests. What people would do is pick up the stool-based test and take it home. It generally has a small collection container as well as all the materials you need for a collection. And in this case, with this particular test that we use at UI Health, a small sample is taken of the stool using an applicator where you don't have to touch anything, but you can actually get the sample from the stool and then bring it back to the doctor in a collection vial, at which case, if the stool sample is positive for a possibility of having blood, then the recommendation would be to undergo a colonoscopy for further testing. Next slide, please. Whereas colonoscopy is more of a direct examination of the colon. And this image just shows the colon itself, like we showed earlier, but in this case with the colonoscopy or the colonoscope in the colon. And the idea is to go all the way through the colon with the exam and visually look in the colon to see if any polyps or other abnormalities can be detected. The procedure is done carefully and generally with sedation, so there's generally not much discomfort other than maybe some bloating or cramping during the exam. The goal of the exam is to identify polyps and, if safe, to remove them during the procedure, which lowers the risk of developing cancer or dying related to colorectal cancer in the future. And if someone actually is found to have a cancer at the time of their colonoscopy, they can undergo a biopsy, which would help diagnose a cancer, as well as get further information about the size and location of the cancer that can help plan their further therapy. Next slide, please. So I put this up because one of the things that when I talk to patients about colonoscopy that I hear the most is actually they don't complain about the procedure, they complain about the bowel preparation. And bowel preparation is a very important aspect of colonoscopy because you have to empty the colon of stool in order to be able to look and examine the colon carefully during the examination. So this is actually a slide I created using, believe it or not, these are mason jars that have coffee in them. So it's not anything off-putting, but the idea is that the cleaner your colon is, the more we're able to see through the material to examine the colon. And the prep on the far left side would be an example of someone who doesn't have a very clean colon, that you can't really see effectively the wall of the colon, and you may miss polyps, and they may actually have to have their examination canceled and come back and try again to clean out the colon. Or the bowel preparation may be sort of adequate to see through, but not really optimal, where we can miss small polyps. But ideally, you would have a preparation more on the right, where it's kind of just yellowish fluid that is coming out of the colon once you've taken the bowel preparation, which really allows us to do a very effective and thorough examination of the colon to remove even small polyps or find any abnormalities, so that we could make sure that we detect anything as early as possible. Next slide, please. So what if you're younger than 50 and you don't currently fall within screening guidelines? So the very important thing to know about if you're younger than 50, it doesn't completely eliminate your risk of colorectal cancer, as I mentioned with the unfortunate case of Chadwick Boseman. But the important thing to know is it's very important to talk to your doctor about any abdominal symptoms that you may have, particularly if you've seen any blood in your stool, other than occasionally people with hemorrhoids may see some blood with wiping. But if you see anything more than that, definitely bring it up to your doctor. If you have unusual abdominal pain or weight loss or change in your bowel habits, or if you've been told that you have anemia that can't be explained by another disease or other cause. So those are important things to bring up at any age, which can help you undergo a diagnostic exam, which may be able to find something before the age of 50, even before you're really within that screening range. And then in addition to that, knowing your family history in terms of your parents, siblings, or others in your family who may have a history of colorectal cancer or polyps, and particularly at what age they may be diagnosed if they had a cancer. And that would help to know if you would benefit from undergoing screening earlier than the currently recommended age of 50. I'm not sure in regards to Mr. Boseman what his family history was or if he had any symptoms, but in many times we are able to identify in younger people before they have advanced disease if we know about a family history or if they express any kind of concerning symptoms. Next slide, please. So lastly, I just say the most important thing, it's not so much which test, but to get screened. So having any of the screening tests would be very important. And we know that undergoing the guideline recommended screening can lower your risk of death related to colorectal cancer by as much as 60%. So certainly screening is very important for the control of colorectal cancer. I'm happy to answer any questions about the details of anything that I mentioned or other questions that come up as well. Next slide, please. And I think that's the remainder of my portion. And I wanted to keep it short to leave all the opportunity to answer questions towards the end of our discussion. So thank you very much. And I'll pass the microphone over here to Candace for the remainder of the presentation.
Hi, everyone, and thank you so much for participating. Great information from both Dr. Naylor and Dr. Lisa Tessing-Humphreys, because both of those are very great information because they speak into the nutritional portion and they speak to the physical portion as to how colorectal cancer affects you. I was diagnosed with colorectal cancer at 35, not knowing at the time that I had a family history, but it took 6 months for them to find out that I actually had colon cancer because I didn't fit the criteria for colorectal cancer, and that was in 2003. So they weren't looking for colon cancer. They were looking for other issues. And so I wind up having my right ovaries and then my left ovaries and then my uterus removed, because that's what they thought was the issue. They thought because I had had issues with fibroid tumors and cyst on my ovaries, that it was my cycle that was causing the issues. So I presented the first time in the emergency room in December of 2002, and I hadn't had a bowel movement in 2 weeks. And although I had taken, the necessary preparation to help me go to the bathroom, nothing worked. And I was a bus driver at the time. So of course, they were like, you have a stressful job, your mom of 5 kids. Yeah, that's your issue. So nothing else was ever investigated. So they gave me something and sent me home, and I didn't question it because, these things happen. And it wasn't until after passing out at the steps of the bus that I wound up going to the emergency room again. And of course, because my heart was beating real hard and I was, losing breath, they thought that I was having heart palpitations and that it was probably a heart attack coming on. So, of course, and that's when, once that was determined that was an issue, I was sent to see my OBGYN, had the surgeries, had the blood transfusion, because when I presented at the emergency room, my blood count was 6.4. And so that was the issue, because I had fibroid tumors and endometriosis. Had the blood transfusion, went back home. Everything was going well until after my 35th birthday. And I was drinking water and I couldn't keep the water down. And I went to the emergency room. My primary care physician had them draw my blood first, and my blood count was 5.2 at that point. And then they had me do a fecal occult blood test because they wanted to find out why I was bleeding. Mine is the fact that I didn't have, my uterus and ovaries anymore. And they found that I was bleeding, and they had me do an emergency colonoscopy where they found a grape-sized tumor on the right side of my colon. My entire colon was removed and resected to my small intestine. And so when we start with things like that, so my life changed immediately, and they didn't tell me how that was going to affect my life. Couldn't go back to work. I couldn't eat at that point because everything I ate, as soon as I put it in my mouth, I was going to the bathroom within, moments. And so that was the issue when it comes to diet, because I had to change my whole entire diet. I had to figure out how I could eat now, because the things that I ate, I couldn't eat anymore. And every salads, fruits, and things like that. So everything processed. But the issue wasn't just that. I wasn't able to return to work. I wasn't able to take care of my children. There weren't any services available. And I kind of fell through the the cracks of what they have now, patient navigation, social services. You got navigators everywhere. They didn't have those like then readily available. And despite the fact that I had great insurance, PPO, and went to a relatively good hospital, I still fell through the cracks of all of that and wind up homeless with my 5 children because I couldn't work. I didn't qualify for Social Security, and I had no income coming in. And trying to manage a cancer diagnosis with no services, of course, leads you into a position where you don't know which way to turn. You have 5 children, you don't know who's going to take in your 5 children. And so suicide became my option because I knew I had insurance that would cover them after that, because I was so in a haze of one issue after another that just fell through. And so hindsight, surviving that is why I talk about this, is that because that what happened to me is the piece that no one ever talks about. They don't talk enough about the financial toxicity that cancer puts you in. They don't talk about the issues outside of the hospital. So when you get a cancer diagnosis, it's not just cancer. It's like, okay, now what do? I have cancer. I have to figure out how to work. I had to figure out how to take care of my family. And when those things don't coincide and work together for that patient, then what's happening at home for that patient determines how compliant that patient is going to be in treatment. And so I talk about that because I want doctors and the medical community that sells hospitals, clinics, to think about beyond what you're seeing in front of you. Ask that patient, what are they dealing with at home? So that you know that whatever you prescribe for that patient, does the treatment match the life? No one ever asked me whether or not surgery right then and there was my best option. And now, of course, mine was on an emergency basis, and I totally understand that. But even for some that's not on an emergency basis, they're being prescribed treatment that might put them in a disparaging situation. And so I always ask, does the treatment match the life? And so that's something that we need to be considerate and to think about as patients are going through this process. And so with that, because of the interest of time, I will stop talking and we can answer questions.
Thank you so much, Candace, for sharing your story. Thank you, Dr. Naylor and Dr. Tusing-Humphries, for your great presentations as well. We do have already some questions in the chat. So now, if you guys would like to unmute yourselves and ask the questions, you can do that too. And so, Alicia, if you could help me allow everyone the opportunity to speak. Thank you. So we do have a question in the chat from Audra Anderson. So she said, a polyp was found when I received my first colonoscopy. I later found that an uncle died of colon cancer. When should my children get their first colonoscopy?
That's a very good question. So when it comes to a family history, colon cancer is common enough where people can have someone that they know in their family who has it, but it doesn't always indicate that everyone in the family has a significantly increased risk. There are certain conditions that can make your risk much higher. One of those, the most common one, is called Lymph Syndrome, which is a genetic condition that can increase the risk of colorectal cancer, not only in the individual, but also in their children or others that are directly related to them. So when we find someone who may fit the characteristics and their guidelines to identify who those would be, there's actually a blood test that can be done that identifies whether or not you may be someone who has a genetic cause of being at higher risk of cancer. And those are the people who, not just them, but their family members may have a higher risk. The fact that your uncle had colorectal cancer, that in itself may not necessarily mean your children are at a higher risk, but your own history of a polyp, knowing what age you were and what kind of polyp, and if it had any higher risk features, and that would be a larger size or what's called dysplasia. If any of those things were part of the diagnosis, then it may be that your children would start screening at an earlier age. So part of it is really having a good understanding of your family history, as well as communicating with your physician that history so they can undergo further testing like the genetic or other tests to see if your kids or others would benefit from screening. Because the thing I should mention is, in order to be screened at an earlier age, your insurance has to be able to cover that screening. And if you're diagnosed with something like Lymph syndrome, it covers you for all those different kinds of screenings starting at a much earlier age. So part of this is letting people know how to do it, but also making sure that you have the financial coverage through insurance to effectively be able to get screened. So both of those things are important.
Thank you, Dr. Naylor. So we also have a question in the chat from Nabil. It kind of goes along what you were just mentioning. So Nabil says, if I am 40, can I be screened?
Yeah, so it really, by current guidelines, if you're 40, you don't have any symptoms and you don't have any known family members with a history of colorectal cancer, then you technically generally wouldn't be screened until you were either the age of 45 or 50. Some of that depends on your insurance provider. Right now, Medicaid and Medicare insurance, I believe, is still going at the age of 50 for average risk patients. However, the American Cancer Society and certain other societies have recommended that for African Americans and certain other groups that have higher risk, they may begin at the age of 45. But not all insurances are currently covering everyone at the age of 45. So the important thing to know, once again, is do you have, it can be difficult, but having the conversation with family members to know if there is anyone who had a history of colorectal cancer, and then being aware of any symptoms and what symptoms to keep an eye out for. Because, being the age of 50 or being the age of 40 doesn't mean you necessarily are at a higher risk, but most of us don't know. So you have to ask the right questions to really know if you are at a higher risk. So that's what I would encourage you to do, is get to know your family history and have a good relationship with your primary care doctor.
Great. Okay, great. And so our next question, also for you, Dr. Naylor. So for a person who's in their early 40s who does not have regular bowel habits, normally, would the person be at high risk? And let's say this person has no family history. So yeah, if you could answer that part. It's a two-part question.
Sure. So, I would refer to that maybe as constipation or irregular bowel movements. That in itself doesn't, people with constipation aren't necessarily at a higher risk for colon cancer than those who are not. But if it's a new change, like what Candace had mentioned, is she had sort of the abrupt onset of changes in her bowel habits. So something that changes abruptly, that's something to bring up to your doctor. If you're someone who throughout your entire life has been a little less regular, that may not necessarily put you at a higher risk. But if you're normally someone who typically has bowel movements and things are completely fine, and then all of a sudden you're having very, very few bowel movements or more pain or something unusual to what your previous experience is, then you'd want to discuss that with your doctor to see if there's something that needs to be investigated.
Thank you. And then just to follow up on that, what would be constituted as having a regular bowel habit?
Right. So I had that conversation with people very, very frequently. And there's not really, I'm hesitant to give like very clear sort of, if it's more than 3 days or 4 days, there's something wrong. It really is dependent upon someone's previous habits. Some people have bowel movements, once every 3 or 4 days, and they can feel completely fine. Other people have bowel movements multiple times a day, and they have for their majority of their life, and that's just what their experience is. So usually we characterize it based on symptoms. If you're having bowel movements, you're not having abdominal bloating, pain, blood in your stool, or a lot of difficulty passing bowel movements, then in all likelihood, you're okay, even if you're not going, like maybe your loved one or someone may go more frequently, but that doesn't necessarily mean there's something wrong. But if there's an abrupt change or new symptoms like pain, more difficulty, more bloating, those kind of things, bring that up to your doctor, because that's usually more of an indicator of something that may be abnormal than just the frequency itself.
Great. Thank you, Dr. Naylor. So I do want to again remind everyone that you're welcome to join in the conversation at any time if you would like to unmute yourself and ask a question or share an experience or anything that you would like to talk about. So now does anyone have a question they would like to share or a comment?
Well, I'm sorry, Alicia, go ahead.
No problem. I did just want to mention that if anyone had any questions and they wanted to remain anonymous, you guys can submit it in the Q&A section as an anonymous attendee. And then that way you can keep yourself private while still asking the question. Just wanted to make mention of that. Go ahead, Candace. I'm sorry.
That's fine. That's fine. I just wanted to, in the context of family history, and the biggest issue is that when I do community engagement, people always say is that it's my business. And so we have a tagline called "Family Secrets Kill Families." A lot of times we want to keep issues, in our family a secret, and that's relating to domestic violence, child abuse, molestations, and things of that nature. And of course, health. But in this context, health relation, it is important that you share this information with your family members, because what you don't share with your family members has the ability to put your family lineage at risk. So because I was diagnosed at 35, my daughters had to start their screening at 25. And so then now anyone after that, they have to, so it has to go on the line. And of course we've done the genetic testing as well. So I just want you to think about what you think is your business, Mike. And if you don't think that is, and if you don't think of it any other kind of way, think about this. Think about what can harm your children and grandchildren. And so if that doesn't promote you to do something about it or to talk about it, it should. So I just wanted to share that piece of information.
Thank you, Candace. Okay, Dr. Tusing-Humphries, we have a question for you that someone submitted. Does consumption of red meat increase the risk of colorectal cancer?
Yes, thank you. Yes, it does. And it was one of the probable exposures that I highlighted on the slide from the World Cancer Research Fund. And there's several proposed mechanisms as to why. Some of it has to do with the nutrient content of the meat. So red meat is high in heme iron, which can be oxidative and promote damage to tissue. Some of it is around preparation of the meat. So when you grill a meat, some of the chemical structures change, and then it can interact as well with our gut microbes to promote toxic type of chemicals that are damaging to the colon. And also we're finding more, and actually in some of the research that we're doing at UIC, is that some of the amino acids that are more common in red meats or animal products, which are called sulfur amino acids, can also interact with our gut microbes to produce chemicals that are damaging to the colon.
Thanks, Dr. Tessie Humphreys. I also did I was wondering, I've heard in conversations with some folks that I've had that that there's also a cholesterol relationship with red meat too that might interact with this, but I don't know if that is true or not.
Some of this, I can't speak specifically to the cholesterol piece, but I can say that in red meats and other animal products, you have more saturated fats, which can impact what's called bile acid metabolism in your body. And these are chemicals that help you break down fat in your intestines. And when you're consuming more saturated fat, it changes the chemical composition of bile acids that can be more damaging to your colon.
Thank you.
And then another question we have for you, Dr. Tusing Humphreys, is what are some of the best foods to incorporate into your daily diet for prevention?
I think from my perspective, probably based on the research, the most important thing that you can do, and I think Keith would probably agree, is increase your dietary fiber intake. That will have very important implications for your colon health, directly for your colon tissue, but also the gut microbes that I keep talking about. They love dietary fiber, and they produce chemicals that are then help to keep our colon healthy. And that's dietary fiber you can get from, grain products, but also from fruits and vegetables. So I think the biggest message, I think, for my talk is really skewing what you're eating more toward plant-based foods, less processed foods, and less consuming fewer animal products, I think is really the type of pattern you want to try to move toward.
Great, thank you. Another question regarding diet. Could you speak more about lactose intolerance, as this is one of the causes of severe bloating and constipation?
So this would be in response to consuming lactose-containing dairy products. So not all dairy products, like yogurt, for example, have high levels of lactose. So some people who have intolerance can tolerate some dairy products, but things like milk, they may have a lot of gastrointestinal upset as a result of that. What's important in the dairy products as it relates to colon health is both the calcium and the vitamin D. So for persons that are having intolerance to some of these products, they might look for other sources or even at times supplement calcium and vitamin D to help promote colon health.
And another question we have, what about olive oil? And Carmen, I don't know if you would like to elaborate more on your question.
Can you hear me?
Yes, we can hear you.
Hi, Carmen.
Okay. Hi. Also Italians and Mexicans love olive oil.
So olive oil is a key feature, as you probably know, of a Mediterranean type diet pattern. And it's a type of fat that seems to have important protective effects for the colon as well as for other chronic diseases. And one reason being is that when we were talking about linking diet to your immune system, it seems that some of the properties that when we digest olive oil skew our body toward more of an anti-inflammatory type of immune profile versus a more pro-inflammatory profile. And also what's interesting is when I talk about a Western diet pattern, it's very rich in saturated fats, but when you think of a Mediterranean diet pattern, it's actually rich in fats like olive oil. And when you look at percent of calories that come from fat, the diets are actually quite equivalent. It's just the quality and type of fat being consumed is different.
Thank you. Thank you.
Thank you, Carmen.
Can I ask a question? Is that okay for Keith? So I wanted to get your take, Keith, and maybe, I don't know if Candace is still on, but why we're seeing such an increase in colorectal cancer in younger people. There's a lot of interest from NCI to really understand root causes of this. What's your hypothesis or one of your hypotheses around why this is increasing?
Well, certainly I believe diet does probably have a part to play. Even like you mentioned the Western diet, but the diet that we all consume has changed over the last 30 years. Even if we go back, most of us, if we go back and think about the foods we were eating when we were children in our parents' homes, it's somewhat different than what we're eating today. So that could have a part to play in it. When they look at the type of cancers that younger people have, the majority are still what's called sporadic, meaning that they're not necessarily related to a genetic cause of their cancer. But why they're having these sporadic cancers at an increased rate is a little unclear. Now, it's still less than 10% of the total number of colorectal cancers that happen in people younger than the age of 50. So it's still a relatively small proportion, but it is increasing, whereas others are decreasing because of screening. So I believe that there probably is an environmental aspect to that. Some of it also may be that, as healthcare reaches younger and younger people because of changes with insurance and things like that, we may be detecting things at an earlier age than we previously were. So that it could be a skewing based on the time of when people enter the healthcare system. That could also change some of that information as well.
Thank you. Just to let everyone know, we're almost at our time, but we do have 3 more questions. So if you can stick around, that would be great. If you have other questions that we may not get to answer today, feel free to still type them in the chat, and then we can try to get those questions back to you, or those answers back to you. So Dr. Tusing-Humphries, you mentioned heme iron and its relation to colorectal cancer risk. For some of the newer plant-based meats that are made with heme, has there been research on their connection to colorectal cancer risk?
No, not that I'm aware of. And a lot of the research that I presented and what we know about heme iron and its relationship to colorectal cancer is I want to preface, is from these observational type studies. So fewer work has been done where we're actually testing something directly in an individual to see the effect of that exposure. So no, that's not an area that I'm aware of, that there's been rigorous testing to see if there's any effects on the colon directly.
Thank you. And Dr. Naylor, please could you talk about the kinds of outreach being done in communities that are more high risk? Since African Americans are much more at higher risk, do you think that perhaps not enough awareness exists as a whole in the United States? Even with the passing of Chadwick Boseman, I don't think that this cancer is spoken about enough.
Yeah, I would certainly second that. I think that information is always power. So knowing more about what the risk is and which populations are at higher risk is very important. The other thing I'd say is, I think, many times people do know that there may be a risk of things like colorectal cancer, but one of the other barriers, particularly that affect African American or other underrepresented communities, is access to, high quality care. So getting screened at the recommended time and being able to navigate the healthcare system. So one of the things that Candace mentioned is all the difficulties she had in navigating the healthcare system. And unfortunately, that seems to be a burden that is oftentimes increased in our communities as well. So I think there is a multi-leveled issue, but certainly part of it is information, part of it is making the healthcare system more equitable for everyone. And part of it is also, unfortunately, insurance related as well, because insurance, like private insurance and those things, oftentimes the number of doctors available to do screening tests is higher for those patients than patients who may be in a safety net hospital system that don't have as many physicians that are performing average risk screenings. So, all those things certainly play a part. And I just wanted to say one thing about the diet. It's not just a healthy colon diet, but that diet is also a heart healthy diet and a healthy diet for various different kinds of health related issues. So I think what's good for the goose is good for the gander, or, it's good for the entire body. So when your colon is healthy, the rest of your body will be happy as well. So I highly encourage that healthy diet as well.
Thank you, Dr. Naylor. And we do have another question, the last question we have in the chat. What risks or side effects are there to treatments, and are there things that can be done to reduce these side effects?
So I'll take that question. So it really depends on the kind of treatment, because colon cancer, even though we refer to it as one thing, it's actually a spectrum. It depends on the location of the disease, the stage at which it's diagnosed, the health of the person when they're diagnosed, and all those things affect the types of treatment that are offered, as well as the person's individual wishes in terms of the kind of treatment that they want. So, I would say that there's been a lot of advances in both the surgical and medical treatment of colon cancer. And that's why the cure rates at 5 years for early stage is up in the 90% range. So I think overall, the idea, what I want people to come away with is getting screened if you're screen eligible, knowing your family history to know if you need to be screened earlier are the most important things. And hopefully we can avoid you ever having to have the conversation about what to do with a cancer diagnosis, because colon cancer is preventable. So that's the thing I really would want to encourage everyone. But if you do, unfortunately, know someone or you yourself hear that, then you want to get all the information that you can get about all the different aspects of treatment, including the surgical or medical aspects. That would be like chemotherapy or radiation therapy. And that can be very different depending on the situation. So there's not really a one answer to that question, but getting as much information as possible and even maybe getting a second opinion is something to consider.
Great, thank you so much, Dr. Naylor, Dr. Tusing-Humphries, and Candace as well, who had to jump off the call. But I do want to again open the floor if anyone has any final comments before we end. So we do have some comments that people typed in. So there's one comment that says, I just wanted to say that I admire Candace's bravery and courage and wish her the very best. Thank you for sharing your story with us. And then we do have another person that said, thank you to the wonderful speakers. You were really great. So thank you guys again. If you guys in the audience or the attendees, if you think of any other questions, we will be sharing the recording of this event along with perhaps some information as well. And if you feel like you have any additional questions, you're free to send those in, reply to the email, and we'll try to get those answered for you. But yeah, thank you again, Dr. Naylor, Dr. Lisa Tusing-Humphries, and thank you to Candace. Thank you guys for joining today. And also, I would like to thank the Blue Hat Foundation as well. So we'll also be sharing some links and information that the Blue Hat Foundation is doing, especially because this month is Colorectal Cancer Awareness Month. So yes, thank you everyone. I hope you have a great rest of your week, and we will send you a follow-up email soon.
Thank you.
Much.
Thank you. Bye.
Bye.